Hello everyone, welcome to HIM 225. We're continuing our lectures for Chapter 15 in your textbook. We're on page 335 and we're looking at the remaining guidelines for pain. If pain is due to a medical device, it actually refers us to another section in the coding guidelines in Chapter 19, which we'll study later in this semester. Post-operative pain, basically it tells us that this is based on the provider's documentation, as well as whether or not that documentation meets the definition for coding additional diagnoses. We do have codes for post-thoracotomy and post-operative pain specified as acute or chronic. Routine or expected post-operative pain is not coded. We have an example. Patient presents to the physician's office complaining of chest pain. The patient recently had a lesion removed from the lung. So the documentation is post-thoracotomy pain. So we can do pain, acute post-thoracotomy, G89.12, and then if we code the chest pain, we can also code the chest pain. That's the specific location of this post-thoracotomy pain, and that code is R07.9. Now, the guidelines tell us that if the patient has post-operative pain that is not associated with a specific post-operative complication, then we're going to assign the appropriate code from category G89. But if we have post-operative pain that is associated with a specific complication, and the example that they have here is a painful wire suture, then you're going to assign codes found in Chapter 19, which is injury, poisoning, and certain other consequences of external causes. And then you can also add an additional code from category G89 to designate whether or not it is acute or chronic pain. And in this example, this patient had a TURP, which is a transurethral resection of the prostate, and they're coming into the physician office complaining of abdominal pain, and the documentation is acute post-TURP pain. So we'll use a code for the acute post-operative pain code G89.18. And then we'll apply the code for abdominal pain, which tells us where this acute postoperative pain is. Chronic pain, number 4, is G89.2, and there is no time frame for the assignment of chronic pain. If the physician documents chronic pain, it's chronic pain. And we can see that we've looked at these before, the different possible codes related to chronic pain. Neoplasm-related pain is in category G89.3. Let's find... And that neoplasm pain can be either acute or chronic, and it all goes to G89.3. So, and it does not matter whether it's associated or due to cancer, primary or secondary malignancy, or tumor. It's assigned regardless of whether the pain is acute or chronic. It can be assigned as a principal diagnosis if that's the reason for the admission, if the patient's coming in for pain control or management, but then that underlying neoplasm would be assigned as an additional diagnosis. If the reason for the encounter is for management of the neoplasm, but they're also having pain associated with that neoplasm, then G89.3 can also be a secondary diagnosis. And on the top of page 236, let's look at this first example, patients admitted for pain control due to metastatic bone cancer. They also have a past history of breast cancer, and their breast has been removed. So our principal diagnosis here is G89.3 for the neoplasm pain. Then we're also coding the metastatic bone cancer. So this is neoplasm malignant bone secondary, C79.51, and of course it has metastasized from the breast. Then we're using the personal history of breast cancer, and then we are also coding the absence of the breast. So that is what those 4 codes are. In the next example, the patient was admitted for back pain due to vertebral metastasis. So they did an MRI, and that indicated that the disease had progressed. So the patient has a history of prostate cancer with surgical removal. So the bone mets was treated with external beam radiation via linear accelerator using electrons. That code for that procedure is not something we would typically code in HIM. It's a CPT code that comes from the charge master. So what we are coding is this patient has a malignant neoplasm of the vertebrae, and it is secondary. That's the first code. The G89.3 is for the neoplasm pain, and then we are coding history of prostate cancer. Chronic pain syndrome, and I mentioned this in an earlier lecture. This chronic pain syndrome is different from chronic pain, and you only use this chronic pain syndrome code when it's been specifically documented. We also have guidelines here specific to coding glaucoma. I'm not going to read through all of those. I will let you read through those. They're pretty self-explanatory. In your textbook, there are a few things that I want to point out to you. I want to make sure that you take a look at. On page 342, your book talks about Parkinson's disease. Now, I want to show you a coding clinic because there is Parkinson's disease and Parkinsonism are not the same thing, but we use the same code. And this question was brought up in 2017, and the response was that the CDC was aware of the inconsistencies, but they haven't fixed it yet. So when you're looking in the index for Parkinson's disease or Parkinsonism, it sends you to the same code. So Parkinsonism G20, and then if you go, and then of course you can see that there are sub-entries for that as well. If we go to G20, let me click on that and show you. You can see that it also it says Parkinsonianism or Parkinson's disease NOS. So they all code to G20. Also, epilepsy. We need to talk about seizures. Patients can have a seizure and they cannot have epilepsy. So if you look, the code for seizures is out of Signs and Symptoms R56.9. But I want to point out to you that if a patient has recurrent seizures, the code changes, and it goes from the Sign and Symptom chapter to the diseases of the nervous system. Recurrent seizures code to epilepsy, unspecified. So make sure that you notice that. You are aware of that. That's one of the mistakes that students tend to make. And also, oh my goodness, I can't type today. Okay, I want you to look at epilepsy in the index. This is a pretty big category. So Don't try to code epilepsy from the seizures index entry. You'll notice that you have a note here. These terms are to be considered equivalent to intractable, pharmacoresistant, treatment, resistant, refractory, medically, and poorly controlled. So these are all terms that are considered to be intractable. And then the codes are based on, of course, that physician documentation and what type of epilepsy this patient has, whether it's intractable or not intractable. We're going to go to, if we go to this category, okay, we have an entire section for epilepsy in the index. And you can see we have epilepsy, recurrent seizures. Also included with this are migraines, headaches, TIAs, sleep disorders. When we go into epilepsy, we have epilepsy and recurrent seizures. And so you have to be very careful when you're coding here, because there's a difference of intractable, not intractable, with status epilepticus, without status epilepticus. So you need to look at your documentation very carefully. If you need to, break it down, make a list. Say, yes, I have epilepsy. Yes, it's intractable. Yes, I have status epilepticus. So that you can come in here and find these codes, because they are very wordy. A headache, if a patient has a migraine and a headache, they have a migraine. TIAs are transient. The residual does not last. So whatever the patient displayed, whatever condition they had, like maybe they had weakness in one side, or it's common to have a droop on one side of the face, those resolve usually in up to 24 hours. I want you to also hemiplegia is included. So we talked about that in a previous lecture. Be sure that you read that information. On page 349, lecture exercise 15.2, I want you to answer question number 1. So exercise 15.2, question number 1. And then again, take a look at the Z codes that are applicable to this chapter. One of the most common procedures that is done for these chapters is deep brain stimulators and also cataract extractions with an intraocular lens implant. Now I'm going to go over the homework for you real quickly. You're answering for chapter 15, you're answering the odd questions 1 through 19, and I'm going to tell you that all of these questions only have one code, actually 1 through 17. You're not answering 19. So not 19, just 1 through 17. And they all have one code, and number 11 is a Z code. So when you read number 11, family history of epilepsy, that's going to be a Z code. And that will conclude these lectures for chapter 15.